Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and independently sponsored by Amgen.
This program is presented by Medscape Education Global.
Hello, I'm Emanuele Della Torre, Professor of Rheumatology at Vita Salute San Raffaele University in Milan, Italy. Welcome to this program titled Tumor-Like Masses, Abdominal Swelling, Pancreatic Involvement, Making Sense of IgG4-Related Disease and Multi-Organ Fibroinflammatory Conditions. Joining me today are Matthias Lord, Professor of Gastroenterology and Hepatology at Karolinska Institute in Stockholm, Sweden, and John Stone, Professor of Medicine at Harvard Medical School and the Edward A. Fox Chair in Medicine at Massachusetts General Hospital in Boston, USA. Matthias and John are world-recognized experts in IgG4-related disease, and together we will learn about how IgG4-related disease presents, about the diagnostic odysseys of patients affected by IgG4-related disease, about how IgG4-related disease clear presents, and the challenging in managing this disease long terms. IgG4 was first diagnosed in 2001 and now is defined as a systemic immune-mediated disease characterized by fibroinflammatory lesions that might affect every organ system. IgG4-related disease has a relapsing remitting pattern, and there are multiple differential diagnoses that might lead to misdiagnosis of IgG4-related disease. So diagnostic delay might lead to irreversible organ damage and even death. IgG4 promptly responds to glucocorticoids and is named for the characteristic increase in serum IgG4 in most patients and by the presence of IgG4 positive plasma cells in most affected tissues. So John, how does IgG4-related disease present from a rheumatology perspective?
Well, from a rheumatology perspective, there are a lot of different presentations, but I'll summarize what I think the major ones are. Rheumatologists are most likely to see disease above the head and neck, at least compared to other specialists. So we see disease of major salivary glands, submandibular gland swelling. We see disease of the eyes. The patients can present with what used to be called idiopathic orbital inflammation. We are also sometimes refer patients who have pachymeningitis, even though that patient might be seen by the neurologist first. Then we may also see patients with disease below the head and neck. So we evaluate patients with peculiar lung presentations and kidney presentations. And very important, and really an area of unmet medical need, particular unmet medical need, is the retroperitoneal fibrosis, often associated with aortitis.
Thank you, but we know very well that GI manifestation, gastrointestinal manifestation, is probably the most frequently reported in all the case cohorts. So Matthias, what are the most relevant clinical presentation from a gastroenterology perspective?
The manifestation of IgG4-related diseases in the pancreas and the bile ducts are amongst the most frequent organ manifestations. And they can appear to be presenting, say, as a pancreatitis. Then it's called autumn pancreatitis. And then, you have a stricture in the bile ducts, mostly in the distal bile duct, leading to jaundice. So these are the two major manifestations of the disease in the intestinal tract.
Matthias, what about additional gastrointestinal manifestation besides the pancreas and the liver? Is it possible for IgG4 to affect the intestine, for instance?
Yeah, but this is a very rare manifestation, really, within, say, the esophagus, for instance. The liver is a little bit more frequent as to compared to other in the hollow organs, so to say. It's really related to the parenchymal organs, as John explained, the glandular systems. And I may add also the testis is sometimes affected. We had a couple of those patients, very rare manifestation, but typical in a way.
So besides rheumatological and gastroenterological presentation, do you think that there are other, uh, basically more rare presentation that we should highlight for our audience?
Well, certainly taking it from the top down so we try not to forget anything, the pachymeningitis that I mentioned before is an uncommon presentation, but a very important one. And inflammatory disease at the base of the brain can lead to a number of lesions causing cranial nerve abnormalities and things like that. One should not forget renal thyroiditis, which is actually IgG4-related disease of the thyroid gland. And I always try to remember that IgG4-related disease has a predilection for involving glands. So in addition to the major salivary glands and the lacrimal gland and the pancreas, one can't forget the prostate, which is affected in a very high percentage of male patients. And even the pituitary gland can be affected by IgG4-related disease, and the pituitary in particular can be quite devastating.
And so based on what you said, we should expect multiple clinical presentation for our patients with IgG4-related disease. But indeed, there are some red flags that are common to all the site affected by IgG4-related disease. And these red flags have been put together in a recent publication. And basically, there are 5 of them. Swelling in one or more organ systems, in particular with pancreatic and biliary tract involvement, increase in serum IgG4 level in most of our patients, and the binding of IgG4 positive plasma cells in tissues, as well as obliterative phlebitis. These red flags can be used broadly by non-specialists in IgG4 disease, including primary care physicians, as well as rheumatologists and gastroenterologists, non-primarily experts in IgG4 disease as well. John, what do you think about these red flags? Do you use them? Is there something else that guides you in the diagnostic process or in raising the suspicion of IgG4-related disease?
Well, I think those are excellent guidelines. If you need to try to narrow them down to only 5 in this complex multi-organ disease, those are very good ones. Those are ones that I wish every primary care physician knew. That might decrease the diagnostic delay that we have. There are a variety of other features that are perhaps not quite as distinctive, but there are other serological manifestations. For example, elevated IgE concentrations are not unusual at all. Low complement levels in 30 or 40% of patients. And I'm struck by how many patients with IgG4-related disease have atopic disease that is sort of difficult to pin down. And they may have had it for years. And I frankly don't think we understand that aspect of the disease very well. But
You refer to
tip off.
asthma and what other manifestations?
Asthma, eczema, rhinitis, sinusitis, that sort of thing.
And what about GI manifestations? Do you use, besides observing the swelling of the pancreas or a narrowing of the bile duct, some other red flags that might be specifically useful in the gastroenterology field?
Well, patients present typically with rather unspecific symptoms, abdominal pain, weight loss, diarrhea, as a sign of the failing pancreatic function, really. Those are indeed red flags. And then the painless jaundice is another red flag, which could also be IgG4-related disease. And if I may add to the features which I consider very important too, after all, this is a fibrotic disease. So beside the obliterative phlebitis, I think the storiform fibrosis, as it is called, is something which you see in many, not all, but many of the organ manifestations of IgG4-related diseases. And you mentioned eczema. I think this is something that doesn't go away with a little bit of topical steroids, but that is also something which can be a red flag.
As we said earlier on, IgG4-related disease is a relapsing disease. So it might return, it comes back with multiple flares, that every flare might lead to additional organ damage to our patients. So based on what we just said about how to recognize IgG4-related disease presentation, can we use the same red flags to recognize a flare of IgG4-related disease, or are there differential aspects and features?
Yeah. Well, we have to say that prior to the study led by John, the Mitigate study, we took extra care in defining what is a flare. And that is some work which will stay beyond, this one study. And it is, for instance, the new occurrence of, say, an autoimmune pancreatitis, the worsening of clinical symptoms, that is, the reoccurrence of abdominal pain, for instance, the reoccurrence of elevated IgG4, which, of course, is not an organ-specific thing, the reoccurrence of the jaundice. All of those features are very well defined and would make up a flare, which then would constitute the reoccurrence of the disease and give us the opportunity, I should say, or the need rather, to treat those patients.
It seems like both diagnosing IgG4 disease and recognizing flares of IgG4 disease is really a challenge. So, John, can you tell us more about the diagnostic odyssey of this patient? How does it look like?
Oh, well, it is long. That is the characteristic that almost all of them share. When one tries to trace the onset of the disease, it typically is many months, in fact, more often years, and often multiple years, with visits to countless physicians, sometimes misdiagnoses, sometimes tragically, when patients are misdiagnosed as having adenocarcinoma of the pancreas and undergo a modified Whipple procedure for what is anticipated to be adenocarcinoma, and lo and behold, it's not. And I have patients who, with just about every type of organ involvement, who've undergone surgery because it was a presumed tumor.
What are the most common rheumatological differential diagnoses that can come into question when approaching a patient with IgG4-related disease?
Well, IgG4-related disease is a great mimicker for our time. And there are lots of rheumatic conditions that can mimic IgG4-related disease and vice versa. So Sjogren's syndrome, my very first patient was a young woman, referred to me to rule out Sjogren's syndrome. Granulomatosis with polyangiitis shares many of the same organ features of IgG4-related disease and can be difficult to differentiate. We haven't really talked too much about the aorta yet, but large vessel vasculitis, such as Takayasu's and giant cell arteritis, can mimic and be mimicked by IgG4-related disease because of that shared organ involvement. There are multiple types of systemic inflammatory diseases that can involve the eye, causing an orbital mass. And so there again, you have granulomatosis with polyangiitis and sarcoidosis, and even rare cases of inflammatory bowel disease associated with ocular inflammatory disease. So it's a long list.
Yeah. Indeed. What are the most common misdiagnoses in the field of gastroenterology?
John already mentioned pancreatic carcinoma is one of the most pressing, particularly then if, say, the manifestation of the autoimmune pancreatitis is tumorous rather than a swelling of the entire gland and leads sometimes, even at our center, to a Whipple's procedure, which is then taking away the tumor, quote unquote, and then the pathologist is telling you that's IgG4-related disease. Then it can present as an acute or even sometimes chronic pancreatitis. Some few patients also have calcifications in the pancreas. And then with regard to the biliary tract, it can mimic cancer as well as primary sclerosing cholangitis. And the important thing here is that we must diagnose it because it's a treatable disease and we can prevent organ damage. So that is why it is so important to have a knowledge about the disease and the mimickers, as you mentioned.
Can you, John and Matthias, of course, or do you remind any specific case in which you struggled to get to a diagnosis, or cases that were misdiagnosed for a long time, both with IgG4 disease being not IgG4 or vice versa, being something else, and then in your hands being diagnosed with IgG4 disease? Just to give an example of how difficult might be this diagnostic journey.
Absolutely. I've got a good example of both of those, and both of them underscore the importance of an astute pathologist. Not a month goes by when I don't get a patient referred for IgG4-related disease, and I request that the biopsy be sent for review. And maybe it's a kidney biopsy, maybe it's a lung biopsy. And the pathologist says, yes, there are IgG4 positive plasma cells, but there's also necrosis, and there are also neutrophils in this biopsy. And both of those really argue strongly against IgG4-related disease for a diagnosis, rather, of granulomatosis with polyangiitis. That's a regular occurrence. One that is maybe a little bit less regular, but probably more challenging because it is less regular, is a patient I evaluated for the first time about 18 months ago. He was sent to me with a diagnosis of IgG4-related disease. He had lymphadenopathy, and he had masses in his retroperitoneum, and he had a couple of bone lesions. And he had a very elevated serum IgG4 concentration.
So
And he
from here, they refer to you because of a suspect of IgG4.
Right, right. And the patient had actually been treated for IgG4-related disease, and his serum IgG4 had come down, and he felt better. But I was uneasy about the diagnosis, mainly because of the bone involvement, which is highly atypical for IgG4-related disease, especially the long bones or bones of the pelvis. But I thought, well, let's just see how he does, if he continues to improve. And ultimately, I grew quite dissatisfied with his lack of improvement, and had him undergo a biopsy of one of the masses in his pelvis. This also seemed consistent with IgG4-related disease. I was still not happy because of his bone disease. So I reviewed the lymph node biopsy that he had had. I just heard yesterday that it shows imperiopoiesis, which is very typical of Rosé-Dorfman disease. And his bone biopsy, which he's already had, which we don't have yet, I'm sure is going to show the same thing. And it's very important to make the right diagnosis because there is good treatment for Rosé-Dorfman, but it's not the treatment for IgG4-related disease.
Matthias, do you have some cases in your memories?
I have several of those, but a typical misdiagnosis case is a patient who is coming with jaundice, weight loss, abdominal pain, and then, he has on imaging some tumor, quote unquote, in the head of the pancreas, even lymph nodes, which are enlarged in this area. And then there is maybe not a lot of IgG4 elevation in the serum. That is only maybe a slight kind of elevation. And then these patients typically eventually undergo surgery. And then the histopathology would show you that this is a classical, typical IgG4-related, that is pancreatitis, that is autoimmune pancreatitis type 1. Having said this, we try to avoid that in giving, a shot of steroids and very short follow-up of these patients. But it happens once in a while that this is a misdiagnosis of a pancreatic cancer, which is typical, and then turns out to be IgG4-related disease.
You already introduced briefly this topic, but what might be the consequences of misdiagnosing IgG4-related?
Well, if we stick now primarily, say, to the GI tract, and that is the pancreas, patients very rapidly can develop exocrine pancreatic insufficiency, making up the symptoms of diarrhea, for instance, and blown abdomen. And then endocrine insufficiency, diabetes mellitus, is also a consequence of the disease. And rarely, I must say, even biliary strictures, particularly in the distal bile duct, but sometimes even within the intrahepatic biliary ducts.
So this means, to your experience, that the damage in IgG4-related disease might be reversible to some cases if you early diagnose IgG4-related disease?
If one would catch these patients very early, it might be reversible. For the time being, unfortunately, this is irreversible for most of the patients we are seeing, particularly those with pancreatic manifestations, I'm afraid. I don't know.
And the other type of damage that is really important that results from misdiagnoses is damage from inappropriate therapy.
Yeah, right.
From patients being treated with only steroids for years and years and years, because we're in a new era of therapy now. So adverse consequences of inappropriate therapies are a big problem.
So you mentioned glucocorticoids, which leads us to the final part of our roundtable. Glucocorticoids are very effective in IgG4-related disease and leading to remission in most patients, basically. It's a very steroid-responsive disease. However, in nearly half of the patients, steroids fail to control the disease in the long term, or at least to achieve complete remission. So patients might relapse within 1 year. What are the current treatment challenges, John and Matthias, of course, in the management of IgG4-related disease, besides what we have already said about of course, all the diagnostic process, but in management, in the treatment armamentarium that we have?
Well, it really can't be emphasized enough the challenges posed by steroids in this patient population. It affects middle-aged to elderly individuals. It tends to target the pancreas. So to have to treat patients with steroids for years is highly problematic. Um, it is also important to identify the extent of disease. There can be subclinical disease in a variety of different organs. Maybe the pancreas is evident, but there may be disease in 3 or 4 or 5 other organs, and it's important to look for that at the outset. Um, it is also important following treatment. It's difficult to know, difficult to predict when a patient will flare. So I think that is an additional challenge in therapy.
Yeah. I mean, as you said rightly, most patients do respond, but as John pointed out, I mean, you cannot treat a patient over years with steroids. So there is a certain need for another, kind of therapeutic approach.
So a couple of other challenges of therapy that I think really need to be mentioned are differentiation of active disease from damage, because the pancreas may already be burned out by the time the diagnosis is made. And so it's important for the clinician to be able to differentiate what is active disease that may respond to treatment and what's not going to respond. That doesn't mean that more therapy isn't required. It doesn't mean that mm, longitudinal follow-up is not required, but it may be that big gun treatment isn't needed. And along those lines, some of the damage that occurs is fibrosis,
Right.
particularly in the retroperitoneum, but truly in any organ. Um, Sclerosing mesenteritis can be a very difficult management issue because fibrosis doesn't respond as well in general to our current therapeutic modalities.
And then I think we need steroid-sparing medications because the steroids also lead to osteoporosis. They support the development of diabetes mellitus, which, again, as we have discussed, is a problem with particular IgG4-related diseases in the pancreas.
I would add that another big challenge is the multi-phase presentation of IgG4 disease itself, because this urges the experience in managing different organ complications, a different expertise to put around the table to manage these patients. So, are there specific situations, Johns, in which you ask for help in the setting of a multidisciplinary approach?
Yes, absolutely. And one of these is for the pancreas, for example. Rheumatologists don't think very much about the pancreas,
I'm afraid.
honestly. And this, ironically, is a disease that targets the pancreas probably, arguably, above all other organs. And it took me a long time to realize why these patients are losing so much weight. It's not because they have inflammation that is uncontrolled, and even though it is uncontrolled, but that's not the reason that they're losing so much weight. Typically, if they lose 30, 40, or 50 pounds, they're doing so because their pancreas has failed. They have exocrine pancreatic failure. The pancreas isn't making the digestive enzymes required to digest food, to absorb calories and nutrients, and the weight just falls off patients. So that is an area where I definitely need help from gastroenterologists, but um, also in eye disease, in trying to rule out other conditions of orbital inflammatory disease. It's really important to get a good biopsy, and for that, I need an ophthalmologic surgeon. Renal problems, a nephrologist is often helpful, and sorting out the pulmonary disease, which is so diverse. There's so many different lung manifestations of IgG4-related disease, and that overlaps with the atopic features. So I often have to refer to a pulmonary colleague for help in that regard.
What about your experience, Matthias?
So first of all, I'm very happy that John learned the 101 on the pancreas. But I mean, conversely, honestly, this disease has brought us very much closer to the rheumatologist. So I think the key here is a multidisciplinary team where you have rheumatologists, you have maybe urologists, nephrologists, dermatologists, ENT doctors who can then take over the respective part. We have learned a lot as a gastrologist from the rheumatologist how to manage the disease and really work together on organ manifestations, which we typically don't see. The pancreas, obviously, we can handle as much as the bile ducts, obviously, but all the other manifestations do require special knowledge, which typically is going beyond your own kind of turf, so to say. So one can only urge, if you have such a patient, to seek the help of a dedicated center where you would have the specialists lining up, quote unquote, and contribute with their respective expertise from their field.
And we shouldn't forget the pathologists. Absolutely. Because they can pull us back from making the wrong diagnosis. They can point us in toward the right diagnosis. Another mimicker that I didn't mention and dwell on is the histiocytoses. They can be very challenging, and a good pathologist is essential in sorting that out.
And a radiologist.
Radiologist as well. Yeah, that's indeed right. Because there are features that now our expert radiologists are educated to recognize in terms of some specific organ presentation, like the pancreas, like the orbit involvement, the retroperitoneal fibrosis, and so on. Thank you, John. Thank you, Matthias. We finally got to the end of this roundtable where we learned that there are red flags that should prompt suspicion of IgG4-related disease and about common misdiagnosis of IgG4-related disease that should be considered and excluded. It is important to know how to recognize IgG4-related disease because early approach, early treatment might prevent end-stage organ failure. Thank you, John. Thank you, Matthias. And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.